Good morning, students. Today we will discuss about the pleural conditions like pleural effusion, empyema, and pneumothorax. Before starting the disease process, we should know what is pleura. I think you remember, everyone should remember this pleura. Pleura is a stress membrane covering of the lung. It has two layers, visceral pleura and parietal pleura. Visceral pleura is the one that is opposite to the lungs, and parietal pleura is the one that is lying in the thoracic cavity. So there is in posterior aspect, neural connections start from C7 to T12. It will be in the midline, but in anterior aspect, from fourth space onwards, the parietal pleura slightly reflects to the laterally parasternal region, and it will reach 8th space in the mid-lateral line, 10th in mid-axillary, and 12th in mid-scapular line. So lower border of the pleura is mid-clavicular 8th, mid-axillary 10th, and mid-scapular 12th. Lower border of lung is 6, 8, and 10. So there is a rhesus between the lung and the pleura, and this rhesus is called postdiaphragmatic rhesus. So whenever any collection is there, this rhesus is the first to fill up. Normally, there is some fluid in the pleural cavity. This fluid comes from pleural space. Fluid in pleural space comes from capillaries in the parietal pleura and is removed by lymphatics in the parietal pleura. Sometimes interstitial fluid also may seep through visceral pleura into the pleural space, and some amount of peritoneal fluid also may go into the pleural cavity through the defects in the diaphragm. Whatever the way of entry into the pleura, the lymphatics will remove all the fluid that is entering into the pleural cavity. The capacity of absorption of the lymphatics is about 20 times the normal fluid formation. So this is how the normal lung will be like this, and when there is any collection, the lung will slowly collapse and rise towards the hilum. So etiology of pleural effusion. Whenever there is increased pleural fluid formation, whenever there is decreased pleural fluid absorption, or when there is more fluid formation and lowered absorption, we will be having accumulation of fluid, and that is called as pleural effusion. So increased pleural fluid formation occurs when there is any lung parenchymal diseases like infections and inflammations, which will increase the interstitial fluid formation, and that will go enter the pleural space through the visceral pleura. Similarly, increased intravascular pressure of the pleura also will cause pressure will cause the seepage of fluid into the pleural cavity. And increased permeability of the capillaries in the pleura also will be a cause for increased pleural fluid formation. And increased fluid in the peritoneal cavity also sometimes leaks into the pleural space through the diaphragmatic defects. And sometimes there is a disruption of the thoracic duct or disruption of blood vessels, which result in the fluid accumulation in the pleural cavity. Decreased pleural fluid absorption occurs when there is an obstruction to the lymphatic drainage, as in case of malignancies or sometimes in the case of systemic vascular pressure elevation. Into presentation of pleural effusion. Whenever the fluid collected into the pleural space, slowly it fills the creases, postdiaphragmatic creases, and accumulates upwards. Whenever the pressure increases, fluid formation is increased. Slowly, the alveoli will collapse nearby, and lung collapse occurs because of the compression of the fluid. So accordingly, initial stages, generally patient will present to us with some amount of dyspnea. Patient comes to you with presenting illness of dyspnea or breathlessness and exertion. When you inquire, you will know that there is a chest pain initially when the starting occurs, starting of effusion occurs. There will be some amount of irritation in the parietal pleura, and there will be some pain. That pain After some time, when the fluid accumulation increases, it disappears, and there will be only heaviness in the chest. And when the irritation or inflammation is there in parietal dura, there will be some amount of dry cough as well. Dyspnea will be generally progressive. Initially, it's minimal, and lateral, slowly it increases. The dyspnea will be increased. And signs, there will be decreased movement in the chest on the affected side because of the accumulation of the fluid, and dull to stony dull note will be there because there is fluid, not an air in the space. And third is absent vessels. Naturally, when the lung collapses, there will be no vessels on the middle space. Shifting of mediastinum occurs to the contralateral side when there is any mass effusion. Investigations. First and foremost investigation that we have to do is chest X-ray. Whenever a patient comes with the history of dyspnea, with chest pains, progressive dyspnea, we always should think about pleural effusion. On examination, when we are getting a stony dull note, we have to go for chest X-ray. And in Ellis S curve, this is a clinical sign quoted by Ellis in 1974. That is, the pleural effusion is having a rising dullness, rising line of dullness from anterior to the posterior, and peak in the axilla in this way. So whenever you see the X-ray of pleural effusion, there will be rise in opacity posterior aspect. This is Ellis S curve. So this is minimal pleural effusion. There is only blunting of postophrenic angle. And this is moderate effusion with minimal displacement of arm. And this is massive effusion with trachea and cardiac displacement, that is mediastinal shift to the contralateral side. Next, once we diagnose the pleural effusion, what we have to do is aspirate the fluid to know what is the cause. So for the pleural fluid analysis, we have to take a needle, 18 gauge needle with a 20 cc syringe. We should aspirate the fluid from the pleural space, and we should analyze for cytological, biochemical, and microbiological. So, what are the composition of pleural fluid? Based on the composition of pleural fluid, the etiology for the pathogenesis will be distinguished. So, Light's criteria. What is Light's criteria? Fluid can be exudate or transudate. You know, I think what is exudate and what is transudate. So, pleural fluid can be exudate and transudate. So, basing on the Light's criteria, we have to differentiate between exudate and transudate. Light criteria is pleural fluid protein and serum protein ratio should be less than 0.5. Is more than 0.5. Pleural fluid LDH and serum LDH ratio is more than 0.6. Pleural fluid LDH and more than 2/3 of upper limit of normal serum LDH. If pleural fluid fulfills any of these parameters, it is called exudate. Otherwise, it is transfer. So when is exudate is found or when is transudate is found is a different issue. The other investigations that we do is ADA, adenosine deaminase. This is important to diagnose tuberculosis. If it is more than 40, we should think more commonly tuberculosis. And cytology should be done to rule out malignancy. Malignancy examination we have to do central cytology. Glucose levels will be less in empyemas and tuberculosis. And similarly, we have to do cytology for to know any RBC are there or any WBC. If there are WBC, we should do the DC, where the lymphocytes lymphocytes are more in case of tuberculosis, and neutrophils are more in parapneumonic effusions. So, what are the causes of effusion? Both exudative causes and transitive. Transitive effusions are generally because of systemic diseases like congestive heart failure, nephrotic syndrome, cirrhosis of liver, Meeks syndrome, hydronephrosis, and peritoneal dialysis. In case of exudative effusions, generally that exudate occurs only when there is any infection inflammation of the parenchyma. So causes most commonly are bacterial pneumonias, tuberculosis, tumors, trauma, radiation, collagen diseases, sarcoidosis, emboli, asbestosis, and uremia. The transitive effusions commonest causes CHF. So the pleural fluid will be entering into the pleural space because of the increased pleural pressure in the pulmonary capillaries, and thus through the interstitial space into the basal pleura into the pleural space. Uh, Tubercular effusion is most common in exudative effusions. Exudative effusion commonest is CHF, and exudative effusion commonest is tuberculosis. Tuberculosis effusion can occur because of the sequelae of the primary tuberculosis, or can be a reactivation, or can be a related hypertensive reaction, or maybe due to a rupture of subpleural caseous corpus. So whatever the cause, whether it is transudate or exudate, the cause should be treated, underlying cause should be treated for pleural effusion. And thoracosynthesis, if patient is having more than moderate to severe effusions, we should go for thoracosynthesis. For mild effusions, underlying cause treatment is sufficient for removing the fluid in the fluid to be absorbed. But in case of moderate and severe cases, we should go for thoracosynthesis. What is thoracosynthesis? Thoracosynthesis is aspiration of fluid from the thorax. First, we have to select the site. The partition should be done and should mark maximum done, area of maximum doneness first. And then we have to introduce the 18 gas needle. Where should we enter the needle? We should enter the needle, introduce the needle nearer to the upper border, lower in the intercostal space. Why? Why can't we put it in the middle? So whenever you introduce a needle, you should remember the intercostal space is bounded by two ribs, upper rib and lower rib. Any rib has a low vascular bundle along the lower border of the rib. Hence, whenever we put in a needle, you are always should put nearer to the lower rib and mostly at the border, upper border of the lower rib. This is the three-way cannula that is used for the process for the thoracosynthesis. In this is the place where we remove this cap and we put a needle, 18 gas needle in this. We fit it with this, and then we have to attach the syringe in this side, and this is the syringe in this side, and a connecting tubing into a water. So when the direction of the lock is in this way, we can draw fluid from the pleural space. When introduced into the needle, this needle is introduced into the pleural space and the syringe is in this way. So when direction is like this, we can draw the fluid from the pleural space. After drawing the fluid from pleural space, we have to turn the lock to this direction, so that this is blocked and only these two are open. So we should push the fluid into the tubing like this. So never ever push or an empty syringe when the lock is open to the pleural space. And another precaution that we should take is with these connections, this three connections are there. These connections should be properly airtight. Any loose connection will result in complication, introducing the air into the pleural cavity. Because atmospheric pressure is very high, it will enter into the pleural, air enters into the pleural cavity very easily. So that precaution should be always taken. Next, this is pleural effusion. Once the effusion is over, what is other things that you have to see? When the accumulated fluid is pulse, it is called empyema. When accumulated fluid is blood, it is called pneumothorax. And when accumulated fluid is milky white, it is hylothorax. Hyle means limp. So milky white fluid is called hylothorax. Empyema. Empyema conditions of that where empyema occurs is pulmonary infections, surgical procedures, trauma, spontaneous pneumothorax, esophageal perforation, thoracosynthesis, subdiaphragmatic infections. Evolution of empyema can be divided into three stages. Excuse me. First is exudative stage. This is similar to pleural effusion only. There will be rapid outpouring of sterile fluid into the pleural space, and later that turns into fibropurulent stage where bacterial invasion into the pleural fluid occurs. Then formation of fibrin occurs, membrane and tendency for loculation. Loculations will be there in fibropurulent stage. And next stage is the organization stage where fibroblasts grow forming inelastic membrane called the pleural peel. Bacteria causing empyema. The Streptococcus pneumoniae, Staph aureus, Mycobacterium tuberculosis, Proteus species, Pseudomonas species, E. coli, Klebsiella, and bacteria species are the causative organisms causing empyema. What is the manifestations of empyema? Generally, empyema will be acute febrile illness will be there. There will be high grade fever with chills and rigors. As there is a pus in the pleural cavity, anything, anywhere in the body, if pus is present, there will be sepsis. So there will be fever and a pain as well. Sometimes there will be cough and expectoration also. When the cause of empyema is some bacterial pneumonias, that causes cough and expectoration as well, along with pain and fever. Now, what are the signs of empyema? Empyema, there will be intercostal tenderness, which is absent in pleural effusion. In pleural effusion, there won't be any tenderness, intercostal tenderness. But in empyema, there will be intercostal tenderness. Similarly, there will be shift of mediastinum to same side. This initial stages of empyema, when there is more of a sterile fluid and later slow loculation occurs in fibropurulent state, at that state there will be shrinkage of thoracic case because of the organization of the fluid, that is pus. So there will be fibrosis. Fibrosis naturally causes shrinkage of the area, and the mediastinum will be shifted to the same side. And as there is shrinkage, naturally there is narrowing of the intercostal space. Then, when do we suspect empyema? Whenever we have fever case with chest pain, pneumonias with chest pain, or any patient with fever with chest pain, you should first examine and suspect empyema. And another thing is when we suspect a pleural effusion, clinically we can suspect only effusion, a fluid in the cavity. So when we draw the fluid, gross appearance is thick, turbid, yellow colored, we should think of empyema. So again, this is the chest X-ray that will show this is normal pleural effusion. So when there is loculations, the X-ray will be like this. It is a concavity, there is some convexity in the chest X-ray. So pleural fluid analyzed as before, like LDH, glucose, protein, pH, and WBC and RBC counts. And again, gram stain, microbiological stain, microbacterial stain, and the fungal smears has to be done. Along with these things, we have to do for blood culture, bacterial culture of sputum, of fluid, both aerobic and anaerobic bacterial culture should be done. What is the treatment of empyema? Empyema treatment is according to the antibiotic culture, we have to select the antibiotic and then tube thoracoscopy should be done, and then fluorosis, thoracoscopy, and decoagulation. See, when the pus is thin or thick, if it is thin pus, we should do recurrent. If it is thin or thick pus, you go for antibiotics. Appropriate culture, according to the culture, appropriate antibiotic should be started. Then you have to do either recurrent corpuscentesis or closed tube tracheostomy. If the fluid is less, if empyema, if you think the thin pus is there and it is a minimal amount by X-ray, we can remove recurrent with the corpuscentesis as well. Along with that antibiotics, if you do corpuscentesis, it will be curing the disease. When the pus is thin. And sometimes when the moderate effusions are there and the fluid is thin pus, Then also, along with the antibiotics, we should go for tube thoracostomy, closed tube thoracostomy. That is, intercostal tube is introduced into the cavity to drain the pus. That will cure the empyema. The tube should be introduced into the chest wall and should be kept in the chest wall until there is no drain for 48 hours minimum. So when the drain is completely absent for 48 hours, we can remove the tube. Otherwise, we should keep the tube. If thin pus is there with antibiotics and with close to the thoracostomy also, if the pus is still coming even after 1 week, then we should go for wax. Either thick pus also, we should, along with antibiotics, we should go for wax. And what is wax? Wax is video assisted thoracoscopic surgery. Where thoracoscope is introduced into the pleural cavity, and then you have, because thick pus is there, naturally there will be loculations. So if you introduce a tube, that loculations cannot be broken up. Only the big locule, that is where we keep the tube, will be drained, and the remaining pus will be kept inside. So if you do thoracoscopy, you can break the locules and we can remove the pus completely, and thus we can cure the condition along with the antibiotics. If this is also failing, if wax is not clearing the empyema, then we should think of thoracotomy. Thoracotomy means parietal pleural removal. This again, if it fitness is not there, we should do open drainage. That is, a tube is open to the open, just kept openly, and fluid will be coming out. And if we, when once it is comes, patient comes to fit for fitness, fitness is better, and then we go to thoracotomy. That is decortication. This is how we have to manage impairment. Now, next is pneumothorax. What is pneumothorax? Collection of blood in the pleural space is pneumothorax. What are the causes of pneumothorax? Trauma, penetrating trauma or non-penetrating trauma, or sometimes iatrogenic. And during some procedures, we may break some capillaries and cause a pneumothorax, and then tuberculosis, pulmonary embolism, rupture of aortic aneurysm, malignancy, complications of anticoagulants, and sometimes spontaneous pneumothorax can occur. So, similar to other conditions also, in effusion, just like effusion, pneumothorax also is a fluid. Blood is there, but it is also a fluid. So there will be decreased movement of chest on affected side. There is dull stony dull note under percussion, and there will be absent destinies. And shift of mediastinum to contralateral side also may occur because of the accumulation of more amount of blood. The treatment is immediate tooth thoracostomy. There is no other treatment. We should not do aspiration for hemothorax. We should do tooth thoracostomy, or if hemothorax is not being closed, we can do injects also. And as the blood is good culture medium for bacteria, hemothorax, if it is not drained properly immediately, it may turn into empyema. Then pylothorax. Pylothorax is milky white turbid fluid that is linked in the pleural space. Lymph occurs because when there is any disruption or a symptom. Or when there are some tumors like lymphomas, there will be collection of lymph in the pleural or some iatrogenic injury to the parasite. Diagnosis is by color itself, and triglyceride fluid more than 110 milligrams per day will be there in the fluid. The same thing for pylothorax also, the same physical signs will be there. There is decreased movement of chest in the affected side. There will be dull to stony, dull note in the percussion. There is the absent presence in musculation. A shift of mediastinum more or less onto the left contralateral side if their note is more. Treatment is again the same, true to forecasting. But in case of pylothorax, because the loss of lymph is more, you have to do hyperamylation, means supplement, IV supplementation of amino acids should be given, and fluoridesis, because the lymph accumulation generally first being the malignancies. So we should think of pleural disease or sometimes pleuroperitoneal shunts and ligation of thorax. Next is pneumothorax. Still now we have seen the accumulation of fluids, various fluids in the pleural cavity. Now, accumulation of air in pleural cavity we should learn, and that is pneumothorax. That's a classification. Pneumothorax can be classified as spontaneous pneumothorax and traumatic. Spontaneous means it's occurring by itself without any injury or anything. Trauma means with injury. That's the only difference. So spontaneous pneumothorax can be a primary spontaneous pneumothorax or secondary spontaneous. Primary means without any cause, secondary means with some cause. And trauma, traumatic, where it can be because of iatrogenic trauma or can be non-iatrogenic trauma. So spontaneous, primary spontaneous pneumothorax is no underlying lung disease will be there, and there is no presbytic lesion. But secondary spontaneous pneumothorax generally occurs in some underlying lung diseases, and some precipitating event will be there before development of pneumothorax. In case of trauma, accidental, that non-iatrogenic, can be blunt and penetrating. And iatrogenic occurs, as I told you in previously, thoracosynthesis. If you do a thoracosynthesis procedure not in a proper way, then there is a loose connection, there we will be introducing air into the pleural cavity. And similarly, central venous catheterization. When a patient is having any hypotensions, when there is any requirement for dialysis, we'll introduce central venous catheter. And that procedure, during that procedure, you may cause pneumothorax. And mechanical ventilators. Generally, nowadays, this is more common cause for traumatic injury to the causing the pneumothorax. Mechanical ventilators, when they are in patient is on ventilator, if you are not properly adjust the pressures, there is some barotrauma occurs and patient may develop pneumothorax. Hmm? So primary spontaneous pneumothorax occurs more in males than females, and relative risk is more with smokers, about 7 to 10 times higher. And tall and thin individuals are more prone for blood formations and primary spontaneous pneumothorax. And peak age is generally early young age, that is less than 20 years or early 20 years. In middle age, there will be any primary spontaneous pneumothorax. Secondary spontaneous pneumothorax is more serious than primary because underlying lung also is damaged. There is compromised lung function in already compromised lung function along with pneumothorax is more serious than a PSP. The etiological factors for SSPS, COPD, asthma, pneumonia, lung cancer, and tuberculosis. The traumatic pneumothorax, as I told you, can occur due to direct or indirect trauma, iatrogenic and non-iatrogenic. Iatrogenic traumas are due to diaphragm and mechanical ventilations. Non-iatrogenic are accidental, blunt and penetrating injuries. Pathophysiology. Generally, the lung collapses during, there is always a tendency for lung to collapse, and hence it produces a negative pressure in the pleural cavity. Similarly, the chest valve generally has a tendency to expand. So these two contradictory actions will cause a negative pressure in the pleural space. Air is filled into the pleural space either because of the rupture of the alveolar space, communication of alveolar space into the pleural cavity, or communication of the chest wall, communication developing in the chest wall into the pleural cavity. In either way, the air can enter into the pleural space and cause pleural pneumothorax. So general features, clinical features are there will be sudden sharp chest pain and acute dyspnea. Not like other fusion cases. Neural conditions other than pneumothorax will have hardly any pain except the acute pleural case. This pneumothorax is acute case. Acute dyspnea will be there. Sudden sharp chest pain followed by dyspnea is classical for pneumothorax, and there will be cyanosis and hypertension because of the pressure on the heart. And it is more. These symptoms are more severe in SSP, that is secondary spontaneous pneumothorax, than the primary spontaneous pneumothorax. Similarly, there will be decreased chest movement of an affected side because the lung is collapsed. Absent tactile premises will be there. Then hyperresonant note is there because there is air. Air is always gives a resonant mode, and as it became superficial mode, it will be hyperresonant. Absent resonance will be there even in the presence of residents. Absent resonance indicates it is unmonitored. The trachea and mediastinal shift will be there to the opposite side. The chest X-ray is a definitive diagnostic for the pneumothorax. This with visual pleural line will be clearly shown. Expiratory film is more sensitive than the inspiratory film because the visual pleural line will be clearly seen. SSP should, in some cases of SSP, even Bull's disease and large bulle may mimic pneumothorax. So, in those cases, we have to go for a CT to differentiate pneumothorax from Bull's disease. So, this is an X-ray for pneumothorax. This is normal X-ray, normal chest, right lung. Then this is pneumothorax. This is the air in the pleural space. Why you can observe this? There are markings, vascular markings in this right side, but there are no vascular markings on the left side. That means this is pleural place occupied by air. This is the collapsed lung. This is the collapsed lung, and this is the pneumothorax. So treatment of pneumothorax is decided with the quantity of air that is trapped in the pleural space. Quantification of volume of pneumothorax is done by light index. The light index is done. How to measure the light index is calculated by the posterior anterior view, that is PA view of X-ray chest. The DL is the diameter of collapsed lung, DH is diameter of hemithorax on the collapsed side, and I'll show you. This is DL, and this is DL, and this is DH. This is hemithorax diameter, and this is the lung border, collapsed lung border diameter. So we measure these two diameters, and the percentage of pneumothorax is 100 minus DL cube by DH cube into 100. This equation is now simplified is DH cube minus DL cube divided by DH cube is the percentage of pneumothorax. For example, if DL is 6 and DH is 10, the percentage of pneumothorax is 78.4%. In this case, here we can see the calculation. This is 12, this is 9.5. So the volume of pneumothorax is 50%. So in primary spontaneous pneumothorax, if there is small pneumothorax less than 20%, you can treat the pneumothorax by only bed rest and oxygen. Bed rest and oxygen. Reabsorption of air from pleural space occurs at a rate of 1.25% per day if there is no communication between alveoli and the pleural space. So we can ask the patient to take a rest if it is less than 20%. And supplement oxygen will improve the absorption by six times. Hence, we will give some supplemental oxygenation so that the rate of absorption will be improved and patient will improve within no time. So, moderate pneumothorax of less than 40% also can be treated in primary pneumothorax by a simple aspiration. Simple needle aspiration. If it is Moderate pneumothorax of primary, so spontaneous parietal. Aspiration as not is it is done in the second intercostal space, not like the pleural effusion. In pleural effusion, the fluid will be settled in the lower zone. So needle will be generally introduced in the intercostal space of fifth to sixth intercostal space in the axillary line. But in case of pneumothorax of less than 40%, and if the cause is only primary spontaneous, we should introduce a needle of 16 gauge in the second intercostal space anteriorly in the mid-clavicular line under local anesthesia with a 50 ml syringe, and the air is drawn. So in more than 15% cases, it will be a success. In any percentage, whatever the percent of pneumothorax in SSP, tube thoracostomy is the line of choice. So minimal, that is even less than 20% also. If it is secondary spontaneous pneumothorax, you should put in a tube. So this is another thing that I want to mention. Whenever you introduce air into the pleural cavity during thoracosynthesis, we will get this picture. After doing a thoracosynthesis, we will go for an X-ray, we will get this picture. And this is called hydropneumothorax. Whenever there is hydropneumothorax, there will be horizontal line of demarcation between air and fluid. So this is hydropneumothorax. Now, hydropneumothorax is presence of fluid and air in the pleural space. Sometimes present air also, as in if there is air entry into the empyema cavity. Sometimes when empyema is because of gas releasing anaerobic organisms, it may produce by itself. So pneumothorax can occur in that cases. So tube thoracostomy is the treatment of choice in all these cases. Next, tension pneumothorax. So tension pneumothorax is different from normal pneumothorax. Tension pneumothorax is generally considered to be the pneumothorax which leads to impairment of respiration and blood circulation. Tension pneumothorax tends to occur in clinical conditions like mechanical ventilation, resuscitation and trauma, and some people with lung disease. The mechanism responsible for tension pneumothorax is disruption of visceral or parietal pleura in such a manner that there is only one-way valve development. The ABC shows hypoxia and severe respiratory acidosis. So this is how a pneumothorax X-ray appears. There is lung collapsed lung here, and this is how the tension pneumothorax will be. Mediastinum is grossly distributed to the other side with cardiac and trachea. So cardiac compression is there. Patient will get hypotension also. So what are the etiologies? Tension pneumothorax can occur due to spontaneous pneumothorax also may turn into tension pneumothorax on mechanical ventilation or cardiopulmonary resuscitation or malpositioning of the tube or disconnection of the tube or anything that can cause any pneumothorax and can turn into a tension pneumothorax. Tension pneumothorax is present when intrapleural pressure is greater than atmospheric pressure. So this is how pneumothorax has three types. One is closed pneumothorax, one is open pneumothorax, and tension pneumothorax. Closed pneumothorax is when there is a rupture of alveolar membrane and to the pleural space. This communication between alveoli and pleura is closed pneumothorax. Once the air enters into the pleural cavity, when there is a pressure gradient, and once the gradient is disappeared, there will be no movement. Means it will be closed. Slowly, the same thing happens when the open pneumothorax, chest valve is open into the pleural cavity due to some injury. The pleural cavity pressure is less, so air enter into the pleural cavity, and at some stage it will be equal to atmospheric pressure, and that will end the pneumothorax. We have to drain it. But in tension pneumothorax, this is not the case. Even though the pleural cavity pressure is raised, persistently the air enters into the pleural cavity in spite of increased pleural cavity pressure than the atmospheric pressure. During inspiration, respiratory muscles contract and create negative intrapleural pressure and allow the air movement into the pleural space. And during expiration, when expiratory muscles relax, pleural pressure becomes positive. And the one-way valve prevents the exit of the air into the pleural space. As the tension over the increases, progresses, pleural pressure will be positive even during inspiratory cycle also. But the exit will not be there and influx will be persistently continuing. The decompression of cardiopulmonary function occurs due to reduced venous return attributed to increased intrathoracic pressure, finally heart failure. So, tension pneumothorax is a medical emergency requiring immediate chest awareness to relieve intrapleural pressure. Patient should be given immediate high concentrated oxygen to alleviate the extreme hypoxemia. And then a large bore needle is introduced into the second anterior intercostal space, and then needle should be connected to a syringe partly filled with saline. Air bubbling confirms the diagnosis, and immediately needle should be left in that place, and immediately we should prepare for introduction of intercostal tube. So what is this tube thoracostomy? So we have heard that tube thoracostomy is used for empyema, hemothorax, chylothorax, pneumothorax, several conditions of massive pleural effusions. We need to put a needle, a tube in the thoracic cavity. So, one introduction of intercostal tube into the thoracic cavity is tube thoracostomy. It permits the air to escape through air and fluid to be escaped through tube connected to underwater seal. Air will be evacuated rapidly and effectively. So ICTD is the treatment of choice in all these conditions: hydrothorax, pneumothorax, empyema, effusions, pneumothorax, and calothorax. And this tube is introduced in the fifth intercostal space along the mid-axillary line into the thoracic cavity to drain out air or fluid or pus collected in the pleural space. This tubing, this is a tube that is introduced into the intercostal space, and this is connected to a underwater seal drain. The jar should be filled with the water, and one tubing should be within the dipping in the water, and the other tube should be above the water level. Why? When there is air coming into the water, into this tube, that air should go out, isn't it? So if air won't go out, again this will pressure. If you forgot to put this opening or block this opening, once the air fills this jar, again this blocks, and we can't drain the air into this. Tube will be blocked. So that is why we have to put in a tube again. The second tube also should be present in the jar to remove the air. Okay. So this fluid, by this fluid level, if you put in a tube like this and we keep the tube downwards like this, without the fluid, atmospheric air enter into the cavity, isn't it? This atmospheric air will enter into the cavity, and then if it is empyema, it will turn into pneumothorax, isn't it? So we should keep a jar which half filled fluid, and the tubing should be dipped in the fluid, water. Okay, fluid is generally water. Okay, the tube connected to water will contain a jar and also maintaining and drained out. And another thing that we should take care of is once the the intercostal tube is introduced and it is started draining the space, pleural space. When there is any pressure, massive effusions, massive empyemas, or pneumothorax, tension pneumothorax, all these conditions, there will be high pressure in the pleural space. So immediately the fluid or air rush into the tube down into the jar. So rush, sudden decompression of the pleural space will cause sudden expansion of the lung, and that will lead to pulmonary edema. So when there is a pressure in the pleural space, when we think the fluid is in the pressure, we should be very careful in draining the fluid out. With clamping only, we should drain the fluid. Slowly, the slow decompression should be done when there is any massive effusions or the tension in the thorax. Okay, next. Another thing that I have told you is pleurodesis. So when there is empyema, we'll go for pleurodesis. Once the empyema cavity is completely drained out, once the pleural cavity is free of fluid, we should introduce a chemical into the pleural space and thus closing agent into the pleural space to close the pleural cavity. That abolish the pleural cavity. That is called pleurodesis. This is considered in cases of some recurrent cases of pneumothorax, empyema, and as I told you, pylothorax. And sometimes in hemothorax, if the cause is not trauma, we should think. If it is cause is because of malignancy, we should go for pleurodesis. Then thoracoscopy. As I told you, if failed acidity cases, we go for thoracoscopy. And parietal pleurectomy, thoracotomy or parietal pleurectomy, that is stripping of parietal pleura, should be done in some cases where these intercostal tube drainage or the thoracoscopy is failed. So failed tube drainage, what are the indications of parietal pleura? Failed tube drainage, it's led to recurrence of the conditions, contractile occurrence of the conditions, bilateral simultaneous pneumothorax, persistent peripheral effusion, initial episode life-threatening, which is life-threatening, and special risk groups like air crews and drivers. Air crew and drivers with when they appear with pneumothorax, it is always better to do a parietal pleurectomy. Now, to summarize the conditions of pleura, I have prepared a table here. In case of symptoms of these pleural conditions, chest pain. In case of pleural effusion, there will be chest pain initially because of parietal pleural irritation, which later on slowly disappears. Once the fluid collects, the parietal pleural irritation disappears, and there will be no pain. In empyema, because of the pus, it is always painful. Pneumothorax, pain may be present because of trauma. And pylothorax, there won't be any pain, it's only because of fluid, we may have heaviness. And pneumothorax generally presents with sharp, stabbing chest pain. Fever. Fever, febrile illness is present if there is any pus. Otherwise, in pleural effusions, it may or may not present. In case of pneumonia, parapneumonic effusions or pneumonia effusions, you may have history of fever. Otherwise, there won't be any fever. Fever is not related to effusion, but in empyema, there will be high-grade fever. Similarly, pneumothorax may show some mild fever, but chylothorax and pneumothorax will generally won't be present with fever. Dyspnea. Dyspnea is present in all the cases, and in all the cases, and more or less depends on the accumulated fluid. If the fluid is generally in effusions, it will be progressive in nature. Initially, there will be mild, and later on, with accumulation of fluid, if the patient delays in attending the hospital, it may become more. Hemothorax or chylothorax, all these three conditions depends on the accumulated fluid. If the fluid is more, the dyspnea will be more. But in pneumothorax, it will be moderate to severe. Pneumothorax generally presents with sharp, stabbing chest pain with acute dyspnea. And signs So similarly, decreased chest movement will be present in all the conditions where the pleural cavities are occupied with something or other, fluid or air. Definitely, the chest movement will be decreased because of the underlying lung collapse. Percussion, fluid shows dull note, so all fluid conditions will have dull note or stony dull note, and pneumothorax will show hypertensive note. And in this, I have forgot to put on a table hydropneumothorax. So for hydropneumothorax, percussion note is both dull note and resonance because of the combination of air and fluid, and there will be a sign for shifting dullness. Okay. In auscultation, there will be absolute resonance in all the conditions, and in pneumothorax there will be coin sign which is positive. I hope you remember coin sign. And hydropneumothorax there will be suction splash. Suction splash means when you, as a patient, put a stethoscope on the chest, and if you move the patient, you will get a movement of fluid just like a coconut. So that is suction splash is seen in hydropneumothorax. So treatment. In pleural effusions, as I told you, pleural effusion is simple fluid in the space can be done with thoracocentesis. In empyema, hemothorax, and calothorax, they should be drained through tube capacity. And in empyema, hemothorax, and calothorax, we should introduce irritant in the pleural cavity for fluoridesis. And in pneumothorax, we have to do ICTD, and controlled ICTD should be done because sudden decompression will cause primary edema. I hope you understood everything.